Welcome to the only patient advocate podcast you'll ever need. In this podcast, you'll learn how to advocate for yourself and your family, and where to turn when if that becomes overwhelming. Now, here's your host, Joyce Schulz-Killian, registered nurse and owner of At Your Request Patient Advocate, LLC. She is your private patient advocate. Here at your request to communicate, educate, and advocate with and for you.
Hi, I'm Joyce Schulz-Killian, a registered nurse for 27 years and in healthcare since I was 18 years old. I'm the owner of At Your Request Patient Advocate, LLC. I'm here at your request because I am your private patient advocate, helping you navigate healthcare one puzzle piece at a time by educating, advocating, and communicating with and for you. I'm hoping to give you the tools you need to be your own best private advocate. Find me on Facebook at Your Request Patient Advocate and on Instagram at JSKICURN, and on Twitter at RN Advocate, the number 4, the letter U, so RN Advocate for you. Hit like and subscribe if you like what you hear, and tell a friend. Today we're going to be talking about how to avoid medication errors. And medication errors, I hope this podcast goes a little better than the last one. I have to tell you. Medication error is defined as any preventable event that may cause or lead to an appropriate and inappropriate medication use or patient harm while the medication is in control of the healthcare professional, patient, or consumer, according to the National Coordinating Council for Medication Error Reporting and Prevention. That was the definition. The FDA receives more than 100,000 reports of medication errors every year in the United States. There are about 400,000 drug-related injuries that happen in hospitals every year because of medication errors. And the Institute of Medicine reported an estimated 98,000 Americans were dying annually due to medication errors. This is unacceptable. Medication errors can be prevented, and I'm going to help to assist you in learning how to do that. Medication errors can occur at any stages of the prescription process, and we're going to review that. Medication errors are thought of as a failure in one of the 5 rights of medication administration: the right patient, the right medication, the right time, the right dose, and the right route. These 5 rights have been historically incorporated into the nursing curriculum as the standard processes to ensure safe medication administration. I learned it, every nurse in school learns it, but is it enough? Apparently not. Therefore, 4 additional rights were proposed recently to include the right documentation, the right action and reason, the right form, and the right response. But that doesn't help if your nurse doesn't follow the new recommended guidelines, or if they are at home, or if you're at home and alone with your meds. So one of the best ways to reduce your risk of a medication error is to take an active role in your own health care. Learn about what your medications are. Learn what both of the names of your medication are. If things aren't difficult enough, we have 2 names for every medication: a brand name, something catchy, and a generic name, chemical brand, such as Lasix and furosemide, or Tylenol and acetaminophen, or Advil and ibuprofen, or Coreg and carvedilol. Some things you don't know is that some of the names of the drugs also tell us what type of a drug they are. Like carvedilol, because it ends in an LOL, is a beta blocker. As a nurse, I know that. I also know the side effects of all beta blockers. So see, if it wasn't confusing enough, healthcare, made it even more difficult by giving every every prescription name drug 2 names. The other thing is there's a difference sometimes in the generics and the formulary brand. And I can tell you, because I know this from a fact from somebody I knew who was taking Vistarol for anxiety, and they were taking the Vistarol PAM version, and there's an HCl version, and one is a generic and one is the non-generic form, and they are formed differently. One is formed with sodium chloride, I believe it's the HCl brand, and the PAM version is formed differently. So they work differently in people, and a lot of people don't know that. All right, so now we're going to talk about the process. The process starts with the prescriber, the person prescribing the medication. While you are there, ask, what is the name of this medication? Can you spell it? Now you're there with your doctor, you're sitting there, you're having this conversation. Ask him, spell the name of this medication. Give me both names, because I know there's 2. Give me both of them, because I want to learn as much as I can about this medication. What is this medication for? Why am I taking this medication? What results should I look for while taking this medication? And what are the side effects I may see while on this medication? The other question to ask is, what happens if I miss a dose? Do I replace it? Do I take one immediately? Do I wait till the next time to take another dose? How do I handle a missed dose? All great questions to ask while you're sitting in the doctor's office with the doctor right there with you. All right, so next, the prescriptions get sent one way or another to the pharmacy. Seeing you know the prescriber and the name of the medication because you asked, make sure when you receive the medication, it is the correct medication with the correct name of the correct provider who prescribed the medication. You laugh. I'm hearing you. I'm hearing you laugh. Ha ha ha. I wish I had my sound effects. Ha ha ha. But recently, my household received a medication that had a different doctor's name on the bottle. What, you ask? How could that happen? Well, I asked the same thing to the pharmacy, and their answer was that the pad had no name, and they took their best guess they could. Is it so hard to read it's so hard to read their handwriting. That's what they told me. What? Call me. Ask me who prescribed the medication. Such a simple answer to a simple problem. Instead, we ended up switching pharmacies. I don't go to that pharmacy anymore. All they had was a lot of excuses. And I don't buy excuses. No apology, nothing. Not acceptable. Healthcare is a business. Don't forget that. All right, the next step in this prescription process is you pick up your medication from the pharmacy. So again, check the medication before you leave the pharmacy. The pharmacist should speak with you if this is a new medication and educate you and answer all of your questions, whether they're the same questions you asked in the doctor's office or different questions. Next, the medication goes home with you and you begin to take it. Watch for any side effects you didn't have before starting the medication. Follow the directions, such as if it is to be taken in first thing in the morning or with food. These are all things you should know about this medication. If something out of the ordinary happens, call your doctor immediately. Lastly, hopefully there is a follow-up with your doctor to see the effectiveness of the medication. If not, make one. Now let's talk about a case in point I was exposed to through the CSA Certified Senior Advisor organization that I belong to. CSA case in point, it's called polypharmacy. What is polypharmacy, you might ask? Polypharmacy is described or defined as medication overload, pill burden. Webster defines 2020 the practice of administering many different medications concurrently for the treatment of a single disease. What Webster doesn't do is define and qualify what many means. Case in point. So this is a 90-year-old woman named Helen who prior to a busy holiday season developed some back and hip pain. She decides to go to the immediate care because her doctor office is closed for the holidays, and she's diagnosed with osteoarthritis and prescribed Flexeril, which is a muscle relaxer. Helen filled the prescription and brought it home. her pain subsided, so she never took the medication. Her granddaughter was discussing with a nurse practitioner friend who informed her her grandmother should have never been prescribed Flexeril because it is on the Beers list, BEER''S list. According to Markham and Hanlon, 2012, the Beers list gives guidelines for healthcare professionals to help improve the safety for prescribing medications for older adults. Originally, this was developed in 1991 by Mark H. Beers. The list is intended to decrease inappropriate prescribing and ADEs, and in particular to identify medications or medication classes that should be avoided in older adults in nursing homes. That's a study done by Merriman Hanlon in 2012. I carry a Beers list with me. It has a lot of drugs on it that have like names that, you wouldn't want to prescribe to an elder person that could be confused with another drug. It has drugs with huge side effects on it, like Flexeril. So Helen's granddaughter comes to the home, checks the 15 pills are still in the original bottle, and she disposes of the medication appropriately. So she does confirm her grandmother never took the medication, and now it's gone. A month later, Helen has some elbow pain, which impairs her ability to cook and dress herself, and she decides to see her primary care doctor. Her primary care suspects gout, and he sends Helen to an orthopedic specialist. The ortho specialist sees Helen in 2 days. And he recommends that she be admitted to the local community hospital to have the fluid removed and confirm the diagnosis. So Helen heads over to her local community hospital. The last place Helen should be heading, if you ask me. Helen spends 6 days in the hospital and qualifies for rehab, which Helen agrees to because she's a little weak and wants to be her best when she returns home. 28 days after entering the hospital for the treatment of gout, Helen dies. What? How, you may ask? Gout? No. Helen dies from a medication cascade of events that occurred once she arrived at the rehab, but that started in the hospital when her medications were reconciled. For some reason, the Flexeril made it on her medication list and was given to her in the hospital and then continued in the rehab. Helen had symptoms in the rehab. She was hallucinating, she was incontinent, and she fell. Helen wasn't eating. She became paranoid and was acting out. She was seen by a rehab doctor who sent Helen back to the hospital, and there her decline continued. Long story short, she was found to have a urinary tract infection and placed on antibiotics in the hospital, which led her to having diarrhea, which led to C. difficile, another infection, and to more antibiotics. Helen's hallucinations continued, so a psychiatrist was called in and Helen was placed on more medication. Her granddaughter got involved and called in a geriatric specialist who recommended all medications be stopped, but the damage had already been done. 3 days later, Helen passed peacefully with her family at her side. You think that this is far-fetched? I have a Depakote story that could have had the same outcome. A client of mine was started on Depakote in the hospital after a seizure at home. That's pretty standard treatment. It was her first seizure. She was sent to the hospital. Depakote was started. She responded well. She didn't have any further seizures. There we go again. Seizures. And she was sent to the community, back to a community within 5 days where she could be monitored closely. Remember, this is a pandemic time, so there's limited visitors in the hospital and arranged visitation at the community. Thank goodness. The husband finally gets in to see his wife after 4 days being there, now 9 days being on the medication, and she is slumped to one side in the wheelchair and is drooling and not responding to him at all. Mind you, we have called for report daily and was told she was just fine, no concerns. except they did not know her very well and did not know she was normally up walking and independent with most passive activities, just requiring direction here and there. And if they did, they may have liked her submissive in the wheelchair, much easier to take care of. I'm not going to be one to judge. We insist the facility doctor see her immediately, and the Depakote was stopped and changed to a different medication. The client responds well and recovers well and is back to her old self within a week. That could have turned into one of those horrible, horrible cascading events like Helen had. So now we have Depakote listed as an allergy on this woman's medication list, nor will she receive it ever again. Once in the hospital, once later on, they actually recommended it as part of a behavioral treatment in a very small dose. And I just couldn't believe that after the very bad experience she had, they thought that a very small dose would be okay for her. It wasn't. So how do we prevent this from happening? Things in the hospitals have changed. You won't see your primary doctor, but you'll see a hospitalist that isn't familiar with you or your medication or history. They're going to tell you that they can see your history, that they can see everything on the computer, and they can see exactly what the last thing your doctor did with you and everything that you're on and all these things. But if I were you, I would not trust that, because we know computers are wrong. Misinformation gets entered. People are human. They make mistakes. So I would request a prescription checkup from a primary doctor or pharmacist to review all of your medication from all of your prescribers. I would also, if you're going into the hospital, bring all your medications with you and supplements all the time and ask questions. Discuss with your primary doctor what your goals are. Maybe some changes can be made in a reduction in medications if your goals have changed. Next, after the checkup, decide on interventions that should be taken together to reduce the pill burden if possible. And lastly, schedule a follow-up for review and regroup a few weeks later to make sure the new plan is working correctly. So to recap, taking charge of your health care and learning as much as you can about your medications is the first way to combat medication errors, and partnering with your healthcare team throughout the process is the ongoing answer. That's it. My references are Elliott M. Liu, 9 Rights of Medication Administration, an overview, and then the dictionary I quoted, and then the report by Merriman Hanlon, 2012, regarding medication, polypharm and medication errors in hospitalizations. Thank you and have a great day. And on that note, I would like to thank everybody for listening. If you like what you hear, please hit like and subscribe and tell your friends. I'd like to thank everyone who helped me take the plunge into this podcast and with all my dreams I've had in the past 8 years. Remember, I am your private patient advocate, and I'm here at your request to help you navigate the healthcare system one puzzle piece at a time by educating, advocating, and communicating with and for you. I'm here at your request because I am your private patient advocate. Find me on Facebook at your request patient advocate, and on Instagram at JSKICURN, and Twitter at RN Advocate, the number 4 and the letter U. So RN Advocate for you. Hit like and subscribe and tell a friend. I'm also on YouTube, and you can also text my cell phone, 847-809-1214. I'm always here to help answer your questions or send you information. Thanks and have a wonderful day.